presentation? Yeah. Good morning, everyone. I think next talk which I'm going to cover is very dear to everyone, proximal humerus locking plate. What are the dangers of plating? We all know it's most favored fixation modality. Everyone from small town to tertiary center, super consultant is expert doing filoplating for proximal humerus. We all claim excellent results, but in reality, we have variable functional outcomes. And to be frank, there are alarming complication rates. We all know proximal humerus fractures has bimodal peak. We do see young patient with good bone stock, high velocity road traffic accident leading to fracture dislocations. And second group is elderly patients who present with domestic fall, comminuted osteoporotic fractures. The dilemma is whether to fix this or replace or other options. So we keep debating about fixation versus conservative, fixation versus replacement. See the impact of technology that matters. This is a nice paper by Mark Frankel 2018, and he has mentioned his choice of treatment for proximal humerus fractures. So if you see, somewhere in 1998, this yellow bar is fixation and the blue one is hemiorthoplasty. See the percentage, more hemis, 4-part fracture being replaced. As we got better fixation plates, the number of fixations went up. There was further increase because of locking plates available. And now you can see 2010 to 2015. Now this new bar has come up, which is reverse orthoplasty. Hemi has completely gone down, and probably there is some balance between fixation and reverse shoulder. So I think with available technology, our choice of fixation is going to change. So now we have these so-called proximal humerus locking plates. There are so many companies with different design. I think every design is good with locking options and variable screw directions with suture holes, which makes our job very easy, and they are well pre-contoured to the proximal humeral anatomy. But what are the complication rate? So the literature mentions complication rate which ranges from 3 to 33.5%. I think which is quite alarming. This is common scenario. I'm sure you all must be seeing this sort of x-rays quite often. Now this was the preoperative x-ray. Philos fixation was done. Probably surgeon was quite happy. We took x-ray and you can see there are hardly 2 screws in the humeral head. There is varus reduction, and most importantly, the most important fragment, what Karthik was stressing, greater tuberosity is completely out of the fixation. So this is bound to fail eventually. Another scenario, the plate which is placed too superior with varus reduction. This is again a varus reduction, screws going intra-articular, and again a very nice fixation. Head shaft perfectly reduced, but see, GT is lying on top of the head. So this is bound to give a very poor result. So why particular treatment fails? Probably we failed to diagnose it completely. We failed to look for displaced tuberosities. Inadequate technique or inadequate expertise on our part to reduce the fracture and fix it well. And at times patient factors like osteoporosis, non-compliance, and sometimes even affordability of patient may lead to adverse result. So this is a nice paper, systematic review, recently published. Very well chosen papers, more than 18 years of patient, in last 5 years, minimum 1 year follow-up, 57 articles with a very good filter, and 3,422 fractures. And it includes all sort of studies from level 1 to level 4. And see the results. Commonest complication was intra-articular screw penetration, 10%, varus collapse, 7%, impingement, AVN, stiffness, and non-union, roughly about 2 to 5%. And the overall reoperation rate was 13.6, I think, which is quite significant. Almost 1 in 10 or 2 in 10 patients got reoperated eventually. Within a year, that is more important. Now, screw penetration. In this particular series, they have mentioned two causes. One, primary intra-articular screw penetration. It is an effort on surgeon's part because fracture is osteoporotic. He wants to get a subchondral hold and you go too much deep and intra-articular. And sometimes you are right in the head, but because of varus collapse, there is secondary intra-articular screw penetration. So the tip what they suggest is at least you stay 5 to 10 millimeter away from subchondral bone to avoid primary or secondary. And you have to have at least 3 views intraoperatively, AP, axillary, and maybe 1 oblique to make sure that you are inside the humeral head. I think varus collapse, again, it is very common. Probably we can say this is sort of high-risk group where you can get primary or secondary varus collapse. Fractures which present with varus displacement or alignment to begin with are at high risk. Osteoporosis with medial comminution in elderly patient, again a very high risk group. And most importantly, if you fail to get anatomic reduction, you are bound to lead to varus collapse, which is just unacceptable. Now see the left picture, you feel you have done a reasonably good job, but if you fail to do medial comminution reduction or to augment this medial cortex, then you are bound to fail eventually within 1 year. How to avoid varus collapse? Most important is we have to get our first medial column reduction correct. Second, when you put screws, you have to have 1 or 2 screws which are inferomedial, fixing the calcar or inferomedial part of the head, preferably variable angle so that you can have at least 2 quadrants. Bone graft and cement has been shown in literature to be of great use. And probably peak plates, some literature quotes that as they are less rigid, they prevent varus collapse. Subacromial impingement, again, it could be primary superior position of plate or maybe because of varus collapse. So the tip is at least stay 10 to 15 millimeters below the tip of the GT, rotator cuff, and stay 5 to 10 millimeter lateral to bicipital groove. Avascular necrosis, in this particular series, it was just about 4.6%, but that is again just 1 year follow-up. But normally they present somewhere 2 to 3 years down the line, but most of them are asymptomatic. And there are some literature support which says probably deltoid split is slightly better over deltopectoral. Probably it maintains vascularity. And it is highest with fracture dislocation. So it is very important to counsel patient when you do fixation for fracture dislocations. Non-union tuberosities, I won't spend too much time with this. Karthik has almost covered everything. It's very important to tag them before, fix them well. If possible, put a screw through plate, through tuberosity and transfix it well. If you're not able to do, then probably I won't mind putting a screw outside the plate and fixing here LT is being fixed and here GT is fixed. I think it's very important to securely fix tuberosities. Reoperations, most of the times they are implant removals or ortholysis, and perhaps sometimes you revise it to reverse shoulder arthroplasty or hemiarthroplasty. This is again interesting paper. What is the single most important technical aspect when you fix proximal humerus fracture? This series had 79 patients, the revision rate was 12%, and they found restoration of adequate neck shaft angle was the most important determinant of successful outcome. If it was not achieved, then varus collapse, plate failure, and intra-articular screw perforation was very common. So they concluded accepting varus reduction and inserting 2 calcar screws could not prevent further varus collapse. So sometimes we tend to accept varus reduction and put extra screw. That is not going to work. You have to get your anatomical reduction as near as possible. This is another paper where they have tried to quantify the acceptance of varus limit. So see, if neck shaft is less than 120, then probably implant failure was 30%, and it was 11 if it was more than 120. If you restore to 135, probably it will drop further. So coming back to the principles of orthopedic fracture fixation, you have to restore anatomy, give a stable fixation so that you can start early mobilization. This is something which still we keep seeing after so many years of different conferences. Surgeon has fixed this. I would call this as a day one failure because he has just missed the head which was lying posterior and he had just put screw just bang opposite to the glenoid. You should understand what are the contraindications, head split fracture, severely osteoporotic elderly patient, and if you are not able to achieve good intraoperative reduction in elderly patient, then probably you have to think of other options. Surgical tip to achieve anatomical reduction, use a periosteum elevator, get varus corrected. You can have K-wires as a joysticks to get it reduced and transfix K-wires to maintain that till you fix with the plate. And of course, you can have bone graft, fibular strut bone graft to prevent varus collapse. To conclude, I would say restoration of adequate neck shaft angle is the most important determinant of successful pilose fixation, and tuberosity identification, reduction, and stable fixation is key to a good functional outcome.